Neutropenic sepsis is a systemic infection occurring in a patient who has a low neutrophil count. A low neutrophil count is classically defined as neutrophils below 1.0, but in fact most patients don't get neutropenic sepsis until that count goes down below 0.5. The problem is that the sepsis can be overwhelming and rapidly progressive if not treated fairly aggressively, and that is the message of this presentation, so that we actually help ensure that people have active treatment very quickly. It occurs in patients who've had chemotherapy, most commonly for cancer, but increasingly for other conditions as well. The problem is that a patient can be a little bit unwell, have a slight temperature, and within a couple of hours can be very seriously ill and have secondary organ damage and actually even have their life at risk. It is vitally important that this condition is considered in the differential diagnosis of any patient who is acutely unwell, so it must become routine that we ask a patient, have you had chemotherapy within the last 4 to 6 weeks?
When I started to have chemo, actually you have a long chat with the oncologist, and you feel very much part of a team here at the Berkshire Cancer Centre, and it's really drilled into you that if you feel unwell when you're on chemo, you really must come into hospital, that it's very serious, that you should, you're not a nuisance, you must come in and have this seen to. So I started my FEC chemotherapy, and I knew that I was sort of high risk because my white cells, my neutrophils, hadn't bounced back between sessions, and eventually I was injecting myself with GCSF to stimulate the bone marrow and make this all happen so that I could be treated again. It was after chemo number 5, about 10 days after the treatment. I was at home one Saturday night. It's always a weekend, isn't it, when these things happen? And really quite out of the blue, I suddenly felt unwell. I felt a bit fluey and achy. Not desperate, but enough to know that there was something not quite right. And I checked my temperature, as I always had done, and it was up there 37.6, 37.8. Not the 38 degrees that it says in your little book of chemo rules that you're given. But it was enough for me to know that I needed to take advice. So I phoned the oncology ward and explained what had happened, and they said they'd ring me back in about 5 minutes. And sure enough, the phone did ring, but it wasn't them, it was the clinical decision unit saying, please come in straight away. So I knew that they were taking this very seriously. I felt fine, I felt very much in control. I knew that they'd need to take a blood test. I knew that they'd almost certainly give me IV antibiotics. So I numbed my porta cath area, which is my usual route for bloods and medications. Put a book in a bag and walked down the hill. I don't live very far away, and I was certainly well enough to just walk down, and probably expected to go home that night. My experience in the clinical decision unit was very efficient. The doctors and the team there made sure that I had IV antibiotics very quickly. What took me by surprise was actually being kept in. I was taken to a general medical ward where I needed the antibiotics over the next couple of days to make sure that the infection and the temperature and everything was under control.
Patients who are most at risk for getting neutropenic sepsis are patients who have fairly intensive regimes. The FEC regime, 5-FU, epirubicin and cyclophosphamide, used in the adjuvant treatment of breast cancer is probably the commonest. Regimes that include etoposide have increased risks of neutropenic sepsis. Oral chemotherapy agents such as vinorelbine and capecitabine are also potential causes of neutropenic sepsis, and especially so in patients of poor performance status. It may also occur in patients having highly intensive regimes who are given GCSF. Patients with hematological malignancies, that's lymphoma, leukemia and myeloma, often start their treatment with compromised immunity, so they are all at high risk of neutropenic sepsis. Other causes of an immune system that is compromised, such as those who are on steroids or have recently been on them, or patients with diabetes, also pose increased risk. Patients who have had multiple courses of chemotherapy are at increased risk of neutropenic sepsis, as are those who are elderly or those of performance status because of other comorbidities. Patients with an indwelling line are also at increased risk. There are, of course, patients on chemotherapy who do not have an underlying malignant condition, such as those with severe arthritis or connective tissue disorders, and they too are susceptible to neutropenic sepsis. In summary, neutropenic sepsis can occur with virtually any regime, So always ask the patient, have you had chemotherapy in the last 4 to 6 weeks? The commonest organisms that cause neutropenic sepsis are gram-negative bacilli and gram-positive cocci. They need to be detected by growth in blood culture, but actually we don't get the result of those for 2 or 3 days after the patient presents. So what you need to do is to take the history to find out whether the patient could have neutropenic sepsis. If they're likely to be at risk, then they need to have antibiotics. Then you need to do the relevant tests, namely take cultures from peripheral blood and from central lines and swabs from other areas as necessary, and examine the patient carefully. But the important thing is to get the treatment on board quickly, and our target is to get it on board within an hour of them presenting to the hospital.
Well, it's important to remember that these patients don't always present with a sign across the head saying, I've got neutropenic sepsis. Often the symptoms are very vague and non-specific. So it's important to always have that at the back of your mind, because if you don't think of it, then you're unlikely to diagnose it. The first thing is to know that there's always a hospital trust policy and protocol to follow. So make sure you know where to find that on the intranet. And apart from that, it's basically follow it. Don't wait for blood tests to come back. Don't wait for input from your seniors if they're not around. By all means, call them. But I think it's very important to instigate treatment as quickly as possible, because these patients deteriorate very, very quickly.
Yeah, we find it quite helpful to use the acronym HEAT. H for history, a history of the patient's condition and when the chemotherapy was given. Examination, carrying out an assessment of the patient, carrying out temperature, pulse, blood pressure, oxygen saturations and respirations. If you look at this observation chart, these observations don't look too abnormal. However, this patient was quite sick, and Muse isn't always a good indicator of how sick a neutropenic patient might be. A for action is to get venous access, to get a cannula in for your bloods and to give the antibiotics. If they have a central venous catheter in situ, you can use that. So treatment, it's essential to get the IV antibiotics in as soon as possible and not to wait for the blood results before you do that.
So following the administration of intravenous antibiotics, the important thing is to follow the care plan we have on this document here, which is the red route. Basically, it involves having hourly observations of pulse, blood pressure, and measurement of urine output. If, despite these actions, patient's condition deteriorates, especially if they become more hypertensive or if their urine output is poor, then you should not hesitate in referring a patient to the outreach team from HDU or intensive care, because most patients who are having adjuvant treatment will need to go to intensive care if their condition doesn't improve. We know that death is a potential outcome for inadequately treated neutropenic sepsis. Patients who are hypotensive and who develop secondary organ failure are much more likely to die than those who don't get ill enough for that. In other words, those who are treated within the hour get better outcomes than patients who are neglected. The worst outcome is patients who sit at home too long and don't use their medical alert card and aren't asked the questions, have you had chemotherapy in the last 4 to 6 weeks?
Well, I think it's the same with any diagnosis, but in particular with neutropenic sepsis, if you do miss it, then it can result in really, catastrophic results. The patients become very unwell very quickly. They can have a very complicated, long hospital admission because you've missed this diagnosis. And I think, like any doctor, you'd feel very guilty and you'd feel personally accountable. And that's the feeling that will go with you throughout your career, I think. But I think it's very important to remember the patient at the centre of this, and it has real repercussions for them. So it's very important not to miss it.
I think I would say to try and take on board that bigger picture, because it may be relatively straightforward to say, yes, this patient needs these IV antibiotics every 4 hours, keep doing the OBS and be alert to what's going on. But the patient is going through such a huge process of worry and concern. And I think that knowing that doctor or that nurse really understands the bigger picture makes a huge difference in how you're being treated and how you might begin to expect your treatment to turn out. So if they can just look at your notes and see that you're a cancer patient and have some understanding that you've been through a lot of treatments, perhaps surgery as well, and all the emotional worries and concerns and shock that go with it. That makes such a huge difference to you as a patient because you feel in safe hands then, and I think that helps your recovery.
The key message is to think, could this patient have neutropenic sepsis? And to ask the key question in the history, which is, have you had chemotherapy within the last 4 to 6 weeks? You then need to examine the patient very quickly, take the necessary actions, including blood count and blood cultures, and then make sure that they have intravenous antibiotics within the hour.
Think of it. Remember to think of it.